Greetings, potential co-investigators. Thank you for considering our study comparing operative versus non-operative treatment for complicated appendicitis with phlegmon or abscess. This is a prospective randomized study comparing patients with a likely perforated appendicitis by CT scan who have a phlegmon or abscess. Complicated appendicitis is a challenging problem for general and acute care surgeons and represents about 10% of acute appendicitis cases. Within the last 20 years, the management of complicated appendicitis has transitioned from surgery for all patients to non-operative management in cases where a significant abscess or phlegmon is present. This transition was likely driven by the use of CT scan for the diagnosis of complicated appendicitis. Surgeons began recommending non-operative management, likely for fear of the need for bowel resection to achieve source control. The risk for bowel resection, however, is very rare in acute appendicitis. There are, however, risks of percutaneous drainage, including erosion into the bowel requiring resection, renal injury, and vascular injury, among others. Recently, a single institution study from Finland demonstrated improved event-free recovery and reduced need for reintervention in the surgery group. The number of days hospitalized was slightly shorter, though not statistically better in the surgery group. Almost one-third of patients in the non-operative arm required an unplanned surgery or an additional intervention, while almost half required repeat CT scanning compared to only 10% of surgical patients. We are proposing a prospective, randomized clinical trial to confirm the findings of the Finnish study in the U.S. population. We will include all patients who have perforated appendicitis with abscess of at least 2 centimeters or phlegmon of at least 4 centimeters. The exclusions are also listed here. We plan to randomize patients within 24 hours of diagnosis of perforated appendicitis with phlegmon or abscess. We would expect most patients to be initially planned for non-operative management, and they will be the focus of our study. We hope that once the study becomes known, more patients will be referred for randomization. Patients will be randomized to laparoscopic appendectomy or ongoing non-operative management. We have two primary outcomes. First is the number of hospital-free days in the 60 days following randomization, and the second is the need for additional interventions after primary intervention, which in the case of phlegmon may be simply antibiotic therapy. The secondary outcomes are also listed. For analysis, we will pursue both intention to treat and a per-protocol analysis. We'll use standard statistical tests and have a priori defined two subgroups, those over 70 years old and those with abscesses greater than 5 centimeters. It is our goal to enroll 180 patients across all centers in this study to demonstrate one additional hospital-free day. I, of course, welcome any questions or comments. Thank you.